So thank you very much indeed for giving up your evening for us. What I'd like to leave you with is the question of how can you work with us to destroy hepatitis C as a public health hazard in England? And I genuinely believe that is within our grasp. The key feature about hepatitis C is that it is a flavivirus. It has to keep running to keep replicating, so it can be cured. And when I say cured, it's not like hepatitis B, it's not like HIV. You take the pills, and the pills are 8 to 12 weeks of side effect-free treatment, and you are cured. There is one tiny caveat here, and it's an important caveat, that killing the virus does not completely reduce your risk of problems if you have cirrhosis. And if your disease has progressed to the stage of cirrhosis, killing the virus reduces your risk of liver cancer, but doesn't abolish it. And that's a key reason for getting people early. If I catch them early, I give them 8 weeks of pills, I tell them to go away, they're cured. And that's nice because it keeps the clinic flowing. We now have a number of different therapies. You really don't need to know the ins and outs of the different treatments, but they all work. They cure 96% of patients, and they're all side effect free. The headline about hepatitis C is it's a disease of two different populations. And what I'm showing you here is progression by age to cirrhosis. And you can see that once you've got cirrhosis, you've got a 5% chance of getting liver cancer every year. But these two populations are important because this is liver biopsies done in people born in Pakistan. They were infected at birth. And if you wait long enough, most people with hepatitis C will end up with cirrhosis. So if you see someone in their 70s from Pakistan with hepatitis C, I'll bet you a very large sum they're already cirrhotic. If you look here, these are people in the same study, people born in the UK, and they contract their hepatitis C classically when they start using drugs, which classically is around their 20s. So you can see they follow exactly the same trajectory as the folks from Pakistan, but they're 20 years later. What we are particularly worried about are people who injected drugs 30, 40 years ago, because getting on for half of those will already have cirrhosis. So the pressure is really on to find these people and cure them. When you're old with hepatitis C, you die from it. More worryingly, when you're young, you're at risk of dying from it and you pass it on to your friends. And we think about the hepatitis C population in these different buckets. We think about the elderly who are at risk of dying from it and the young who are at risk of transmitting. For people born in the UK, the dominant risk by a massive factor is using injecting drugs. And the vast majority, Public Health England estimate 90%, I don't think that's far off. So the vast majority of hep C infections will be people who use drugs. And you know as well as I do that that is a very heterogeneous population, ranging from the very disengaged, very deprived communities who use drugs because they're addicted, right up to the high-performing city high flyers who use them because it's a bit of fun and they can. But the hallmark of all these populations is they're not great at engaging with us. And you know perfectly well that persuading people who inject drugs to continue on a course of therapy is extremely difficult. And those people who used drugs in the past, 30, 40 years ago, are highly unlikely to pop into your surgery and say, you'll never guess what I did when I was at college. And that's our challenge. It's finding those people before they get sick. The organisation we are using to deliver this find and treat programme is centred around regional centres. The country is divided into these operational delivery networks. They're funded, and when I say funded, they're generously funded. They have enough money to do an awful lot of good. They have a lot of capacity, they have a lot of nursing staff, and they have an obligation to support the elimination initiatives and many, many thousands of pounds to get on with it. So the resource is there to make this happen. These are all clinically led. Every region of the country has a single named clinician who is responsible for the programme, and he or she will generally have a team of 1 or 2 programme managers, a data collector, 3 or 4 different nurses, and a burning desire to find and treat people. And the reason they have a burning desire is they get 500 quid per treated patient. So there really is a massive incentive and the resource available. And for those of you interested in getting involved, I can assure you the door at your operational delivery network will be wide open with the red carpet buffed and waiting for you. We're really keen to get all these people treated. We've attacked the people with hepatitis C in a three-pronged strategy. The first part, which began, believe it or not, in 2014, we were one of the first countries in the world to use the drugs. We got them before they'd even been licensed in Europe, and we treated everyone with decompensated cirrhosis. So if you were on a transplant list, you got immediate access to therapy. We then moved down and treated all the people with cirrhosis. And the impact of that has been a 25% reduction in liver cell deaths from hepatitis C, a 40% reduction in people needing liver transplants. And in fact, the transplant waiting list has shrunk. Actually, fewer people waiting for a liver transplant because all those with hep C have now been cured and taken off the list. So that was phase one, extraordinarily successful and very effective. We then wanted to turn the tap off. If you're trying to drain the bath, the first thing to do is turn the tap off and stop it filling up. And our focus in the next couple of years of the programme was very much in people in drug services, people actively injecting drugs. And we've set up a huge programme of outreach clinics, outreach support staff. We have people from the Hepatitis C Trust with lived experience of Hep C who go out and engage in the community and persuade people to come in and get tested. We think that's been a huge success in addiction services. We're now testing about 85% of people. We've seen the prevalence of Hep C in drug services drop by 50%. It's now around 10%. In the good old days, we talked about 30, 40%. So again, we think that's been a huge success, and we think we should be seeing a reduction in new cases. Which brings us on to you people, because the area that, excuse me, and it's been a strategic decision, was people engaged in primary care are less likely to be presenting and transmitting, and they're also under people who know about liver disease and will pick them up if they get cirrhosis. So our challenge now is to shift our attack from drug services to primary care. So we want anyone in primary care with a history of a hepatitis C blood test. And I appreciate that you're gazing at me and wondering what on earth I'm doing emphasizing that, but whenever we go through a primary care record, I can promise you I'll find one. There is always someone with a positive test who hasn't managed to make it to treatment. And these are guys we've just got to find and get treated. We want anyone with a past history of injection drug use, whether they've told you about it or not, we'd like to find them and get them tested. Pre-1991, people with blood transfusions received blood that wasn't screened for hepatitis C. The virus was invented in 1989, and it wasn't until 91 that we had reliable tests. So we want to catch those people because they're now an elderly cohort and clearly at risk of dying of NHS-delivered blood products. And that's a catastrophe, both for the patient and for all of us looking after them. I mentioned the population from Pakistan. Pakistan, I'm afraid, is the epicenter of the hepatitis C epidemic. About 10 to 20% of people are actively infected in some parts. They're infected by vaccinations in childhood. Your average Pakistani baby gets 12 vaccinations in the first year, and we think about 2 have a clean needle. The rest are reused. And that, of course, is a catastrophe when you have a high background prevalence of this virus. The final group we're keen to look at are people with abnormal LFTs. And here, of course, we need to be a little bit careful, because if we're not too careful, we're going to get everyone with abnormal liver function tests and a gamma GT of 54 and get them tested for Hep C. And whilst that's a very good thing to do, we need to look at people, of course, in the round and not just as those carrying a virus. I can see everyone sitting back and thinking, how many of these am I going to find? And the answer is, if you start going through your records, probably somewhere around 5%, in some practices as much as 10, 15%. That's an awful, awful lot of people to phone up and bring in for a hepatitis C test. And we know perfectly well that it is quite unrealistic, unreasonable to ask general practitioners to test everyone who's at risk. The people we want are the people who are least likely to come to your surgery and say, I think I might be at risk of Hep C. So we've got to find a way of semi-automating this. We don't want to completely automate it because your general practitioner knows it's probably our most powerful tool. You know the guys who you've always had a little bit of doubt about what they got up to in the past. You know the people who have potentially played around and might be putting themselves at risk. Your basic instincts for who's likely to need testing is probably much more powerful than any tool that we can deploy. We can, of course, easily flag people. We can run through, and Colin's going to tell you some very powerful tools that we can use. The IT solutions are there, but once we've found people, we've got to get them tested and we've got to get them treated. So my ask of you, please, is simply to start thinking about how we're going to do this. We have the resource in operational delivery networks to contact these people. You have lists of patients who are potentially at risk, and we need to find a way of moving that information from those who know about the people to those with the resource to do something about it. What we're starting to set up are in-reach clinics in a number of different areas. People from the networks have gone into primary care with the primary care team, phoned people, contacted them, brought them in for testing and treatment. In other areas, GPs have essentially referred large numbers of patients to the networks and said, you get on, find, test and treat them. We're looking at data governance issues around getting automatic referrals from GPs. So that would essentially leave the general practitioners just to scan through the list, pick up the people who you really think it would be inappropriate to ask, and then leave the ODNs to do the work. We're going to set up in, we hope, September of this year, a web-based testing system. So you can pop onto the website, put in your name and address, and someone will send you a hepatitis C test. And clearly one approach that we can look at is getting text messages sent from primary care to those patients saying you might be at risk of hepatitis. Here's a website that'll tell you more and tell you how to get tested and treated. All of those options are up for grabs. I don't pretend to know what is the best way to manage this in the primary care setting. I also don't believe that there's a single best solution, and I think all the practices that we're looking at this evening will probably have their own subtle and better way of doing this than I can think of. So my message today, please, is have a think about how you could make this work for your patients. Think about how you'd like to find people and refer them, and then talk to your friendly hepatologist who will lay out the welcome mat.